between a thin prep and a sure path is in thin prep, you use a filtration and then collect the cells by using vacuum method. But in sure path, there is centrifugation and the sediment pellet is means it's put on a slide. The same thing here also, see it is collected, the cervical sample is collected either using a swab or the broom, and then the cells are transmitted into the vials, and then they're centrifuged and they're processed and made into pellets, and the pellets are glued. See the same here in thin prep, as I said, there is transfer of the cells using filtration method. But in sure path, you centrifuge and the sediment is collected onto the smear. Let me show in detail. This is how we do in our laboratory. Here in case of a thin, this is an LBC method where this is a container which they use for collecting, inside which there is a cell separated solution. So can you see in this picture a broom is there? This broom is attached to a stick from which the gynecologist will collect the representative samples both from the endocervix and the ectocervical area, and the broom is broken down into this. After this one, the cells are dispersed completely by thorough mixing, and from this we take, using this is the card holder. See, this is our LBC semi-automatic machine, Easy Prep, where you place the slide into this holder, and two vials are placed, and from that liquid material, whatever the gynecologist has said, you take some of that liquid here, and you apply some kind of Easy Prep gel into these two, and then you place it inside this, which undergoes centrifugation at 1000 RPM for about 2 minutes, and then the smears are made. The final smears, as you know, the difference between the conventional PAP and thin prep, I said, in conventional, the majority of the cells are not captured. That could be because of too much of overcrowding of the cells, or overclumping of the cells, or there is lot of neutrophils or other mucous material overlapping. But in case of thin prep, the cells are evenly distributed, and virtually all the sample is collected can be viewed under the smear. Coming to the staining part, we mainly use this for an acid staining as Harris hematoxylin, and then eosin stain for your cytoplasm. The most commonly used is EA36 with OG6. The main principle behind the PAP stain is in PAP inoculum it includes both acidic stains and basic stains. As we all know, the acidic dye stains the basic components of the cell, and the basic dye stains the acidic components of the cell. The first the first staining part is your hematoxylin, and next comes your OG6 or the eosin. Under eosin azure, you have got eosin Y, light green SF, and Bismarck yellow. This eosin Y and light green SF is the main stains which differentiate between the different stages of squamous cells what we have, like mature squamous cells, intermediate squamous cells, parabasal cells, and basal cells. This is just a brief slide on your staining procedure. After that preparation of the smear, you do you rehydrate the smear, and then you stain it for nuclear staining as in hematoxylin, and then bluing takes place, followed by the cytoplasmic stain, orangey and EA36, and then it undergoes into dehydration, clearing, and mounting. See, this is in LBC smear, where you can see the superficial cells and intermediate cells and metaplastic cells. These are how it appears, and these are your endocervical cells like picket fence appearance, which appears in your LBC smear. In this picture, you can see the histopathological sections, like how it will be. This is from your ectocervical area, and this is from your endocervical cells. So cells from here appears like these, and cells from your endocervical parts appear like this. A little bit on highlight on your automation in PAP smears. There is two different types. One is the focal point system, which works in a different manner, and it is called as a primary screening instrument. It scans the SurePath slides as well as the conventional slides, but it's not approved for thin prep slides alone. So at the end of the computer screening, about out of 100 slides we put for screening, 25% of the slides goes into a set to be normal, and the 75% of the PAP test slide will be considered as abnormal, or most abnormal, and it will be pushed on for the pathologist for viewing. Because of the computer's pre-screening and ranking capabilities, the review of the slides by pathologists can be paid more additional attention to the slides which need the pathologist consultation. And this is about the reporting part. The most common and widely used system of reporting is our Bethesda system, which is from 2014, and it categorizes accordingly. First, the most thing which covers is your the satisfactory amount of cells, while it has 5,000 cells for your LBC and 8,000 to 12,000 cells for your conventional smears. The first thing is your satisfactory for evaluation or unsatisfactory for evaluation, and the next is your the general categorization, either it is NILM, that is negative for intraepithelial lesion or malignancy, and the next will be your epithelial cell abnormalities or other interpretations which we would like to give. Coming to NILM, under NILM you have got non-neoplastic findings, and organisms and others. Under non-neoplastic findings, it could be your metaplastic changes, either squamous means metaplastic changes or reactive cellular changes. It could be because of inflammation, atrophy, or any radiation-induced changes. And under organisms, you have got Trichomonas vaginalis, Candida, bacterial vaginosis, that is nothing but shift in flora, most common ones. Then the last is your endometrial cells. Endometrial cells, if it is in a woman more than 40 years of age, we would like to mention it. Why this Bethesda system is widely used is because of its main differentiation based on the terminologies. Like your, we have either NIL, LSIL, and HSIL, and we have a slight gray zone interpretation as ASCUS and ASH. ASCUS is nothing but your atypical squamous cells of undetermined significance, and ASH is nothing but atypical squamous cells suspicious for HSIL. And this is the basic. This is how in pap smear we view the superficial cells. This is a superficial squamous cell, and the intermediate squamous cell. The nuclei of the intermediate squamous cell is considered as the yardstick, because based on the size of the nuclei of the intermediate squamous cell, you compare and consider any cell to go under any LSIL, HSIL, ASCUS, or ASCH. Then these are your parabasal or metaplastic cells, most commonly seen in atrophic cases. This picture, if you could see that the cell bordering is something kind of squaring of the cells, and there is binucleation of the cells, and the cells are seem to be little bit hyperchromated, and there is some aggregation of the cells which is taking place, and the size of the nuclei to the cytoplasmic ratio, what we call it as an NC ratio, is mildly increased. So these pictures suggest and go in favor of a LSIL. While the next picture in this, which we will get to know something called the arrangement pattern. This is a sequential pattern of arrangement. This is a checkerboard pattern of arrangement. And here we'll get a litigation pattern of arrangement, which is nothing but your isolated cell pattern. So in all these three patterns, we will see that the NC ratio is very much increased, means the nucleus is very big compared to the cytoplasm. And there is literally no space in between both the cells. And there is more of this individual cells which is presenting with this kind of nuclear changes. So all these things favor HSIL. So here we see this squaring up, means the cell margins becoming more prominent with binucleation and hyperchromasia, favoring LSIL pattern. But here, when this checkerboard or this individual cells showing this kind of increased NC ratio or hyperchromasia, it goes in favor of HSIL. And coming to the other two terminologies which is in the gray zone, which the clinicians generally don't like us reporting as ASCUS or ASCH, is because it is neither, it is not that appeasing to the clinicians to take a decision on how to go about with the case. So those cases which comes under ASCUS is nothing but atypical squamous cells of undetermined significance, where the cells are like about 2 to 3 times of your intermediate cell nuclei size. A mild increase in NC ratio with hyperchromasia and nuclear irregularity can be seen. But the main difference what we feel while reporting ASCUS and ASCH is this school of fish screening pattern, as you see here. In this school of fish, like all these, plaque of keratinized cells with orangeophilic cytoplasm, with some amount of nuclear irregularity and hyperchromatic nuclei, you tend to term it as ascus. But these kind of loosely cohesive, but not many cells showing that kind of picture of your ascus means atypical squamous cells. Suspicious of HSIL, ask H, where we directly can't give it as HSIL because the number of cells presenting with this kind of picture is very less. But you neither can't omit it because it is not significant, but you have to report it in that case. We give the terminology of as H. That is atypical squamous cells are highly suspicious of HSIL. But in this picture, we get to see the same hyperchromasia, but there is prominence of this nuclei, prominent nucleoli, sorry, the prominent of nucleoli and the coarsely granulated cytoplasm, nuclear chromatin. See, in the previous ASCAS, HSIL, and NSIL, the nuclei is hyperchromatic and there is increased NC ratio. But here in squamous cell carcinoma, which is very straightforward, where you get to see the prominent nucleoli and your granular chromatin with this overlapping of cells, too many aggregates of the cells, too much of pleomorphism, all goes in favor of your squamous cell carcinoma. Also, many a times we don't get to see this classic cell presentations, especially in conventional smears. There we can take this tumor diathesis or this, sometimes this necrotic kind of background, which gives us a clue that we have to search for such carcinoma cells. Now we'll come into this infections. I hope it is clear. Let me explain it again. So there are we take this intermediate intermediate cell squamous cell nuclei as the yardstick for grading the increased NC ratios. So first we'll have to think about LSIL. When there is a mildly increased NC ratio with the spoiling up of the cell borders or binucleation or some crowding happening. And second thing is HSIL, where there is the cells becoming individualization or isolation or litigation cell pattern or your checkerboard pattern. There are just 3 to 4 cells with, just trying to mold to each other, or there will be a cluster of cells with hyperchromatic nuclei. But when we come to this ASCAS and ASC-H, the number of cells presenting as LSIL and HSIL, the number of cells are reduced, and also not many cells are showing this kind of hyperchromatic picture. But we can't neglect it. We have to rule out the other conditions like reactive cellular changes due to inflammation or atrophy. Means many a times this metaplastic cells present like this. So in that case, after ruling out these conditions, we can name them as ASCAS and ASC-H. The final thing is your squamous cell carcinoma, which is more evident because of the coarse chromatin of the nuclei and the prominent nucleoli. Also, some of the background is kind of tumor diathesis with necrotic background. That's it. Now we'll go into an infectious part. The most, quite I feel it is more difficult in diagnosis until unless many trichomonas should be there in the smear. It will have this flagellated type, which I can barely tell you that I have never seen a flagellated trichomonas in a conventional smear. So when there is highly suspicious, I would suggest an LBC for diagnosing a trichomonas vaginalis, where this is a trichomonas vaginalis. It is more with the nucleus, eosinophilic granules, flagella, in order to distinguish from this trichomonas from other cytoplasmic fragments. The next is most common infections which we find is candida, where the pseudohyphae forms can be seen with elongated budding yeast. And sometimes we'll have the sheesh kebab appearance, which is nothing but that whole the candida pseudohyphae, the stick like a candida pseudohyphae, with surrounded by this, which is smeared by this epithelial cells, giving an appearance of a sheesh kebab appearance. Next, this is a shift in flora suggestive. This individual squamous cells covered by a layer minimal inflammatory cell in the background. But while diagnosing for a bacterial vaginosis in an early pathologist or a budding pathologist, you should make sure that same kind of picture should not be there in the background. So if it is there in the background and if it is there on the squamous cells, it is not bacterial vaginosis. Such kind of this granularity only on the squamous cells with a minimal inflammation in the background, you can call it a shifted flora, suggestive of bacterial vaginosis. While these are the other less commoner seen species where you have this cotton ball or a woolly ball appearance and a lot of acute inflammatory responses seen. This is our classic triple M of our herpes simplex, where you will have multinucleation, nuclear molding, and this ground glass appearance of your nucleus. And this is taken from a conventional sphere, where you will have the small round of polygonal metaplastic cells with slightly enlarged NC ratio. See the same. They are very finely granular, and there is an evenly distributed chromatin with a very small and sometimes inconspicuous nucleoli. But the cell's cytoplasm is little bit abundant. While we compare to our LSIL, where this nuclear cytoplastic ratio is more, and the nuclei tend to be more hyperchromatic, and also this the arrangement of the cells is not this neat. You can see that individual cells with the yeah. This is a picture with atrophy, where similar the parabasal cells also tend to have higher NC ratio. But here, what we can see is the the nucleus here. Yeah, here in few pictures, in few of the cells, you can see the NC ratio is very high. But the adjacent cells tend to show that the nuclei is very neat, the cytoplasm is bluish color compared to your now we end up with the infectious part, which we encounter very less commonly in clinical practice. There and atypical glandular cells. This could be either encounter endocervical adenocarcinomas or adenocarcinomas of endometrial endocervical origin cells. So here we can get to see this as an atypical endocervical cell, where the sheets of cells but quietly enlarged round to oval nuclei with prominent nucleoli. The chromatin is also finely granular. If you could remember the first picture where I showed you the picket fence appearance, where you had this ovaling shape, means the columnar shape of the endocervical cells will be there. In case of a normal endocervical cell, which is present. But in case of atypical endocervical cells, this cell cluster tends other one next to the other. But here it tends to form more of a sheeting pattern. The chromatin is finely granular, but with occasional, you tend to see one or two mitotic figures also. But this is again an atypical endometrial cell pattern. This is something like what we see in our histopathology sections also. This is a three-dimensional group of small cells. Then now I'll be briefing about how what kind of report we will be giving and what is the appropriate follow-up required, which we generally tend to mention it in this mirror. The first is if the specimen is adequate, we give it as satisfactory for evaluation, and then under satisfactory for evaluation, if the satisfactory could be either limited satisfactory because we see very high amount of in that condition, we ask them to repeat the pap smear. What other or the other one is your unsatisfactory smears. Then the complete smear itself is filled with inflammation, and you don't get to see the amount of squamous cells which I mentioned, like 5,000 for LBC or 8,000 to 10,000 in conventional pap smears. If the changes what all we see, the basic benign cellular changes are nothing but or radiation. In those cases, we ask them to treat accordingly, or sometimes when there is too much of inflammation, we ask them to give a course of treatment and then repeat the pap smear again. And if there is any infections accordingly, like trichomonas or the shifting flora for bacterial vaginosis or candida, we ask them to treat accordingly. Then we go to the epithelial cell abnormalities, where we have ASCUS, ASCH, LSIL, and HSIL. Do a colposcopic biopsy. And for all the other glandular other endometrial cells which have come in the smear, we ask them to do further go into a gynecological opinion. Now coming to the almost the final of the slides, like quality assurance and quality control. In quality control, we should mainly concentrate on the technical procedure and the processing issues. And in the by doing so, we get the quality outcome. The ultimate outcome is your quality assurance. So this if the technical procedures are carried on very right way, like without any not much of air drying and the cells cleaning, or then the quality assurance is maintained. But still the same slides have been passed down to 2, 3. Even for your reporting. This is one inspection with acetic acid application. This is mainly for they can view it in the naked eye itself by applying 3 to 5% acetic acid swab into the uterine cervix without any magnification. They will. This helps to detect the acetobite lesion. So once they detect the acetobite lesions, they can take a representative sample only for bed. But the main limitation of this is this has a like if there is an asteroid lesion, you give a suspicious of malignancy, and we don't see anything in the smear. So it creates a kind of over treatment of the situation, and it requires a good amount of training also. But the intention of this VR is not to replace cytology, but to lessen the burden on the resources of the primary and secondary health infrastructure so that they can concentrate more on those acetobite lesions. Thank you, one and all.
Thank you, Vijitha. Any questions from the audience?
Dr. Vijitha, I have a question. So, in your hospital, are you routinely practicing this HPV testing? Do you advise routinely and do you get the requests also? How much the practice?
Sorry, sir, can I have your question again, please? There is a break in voice.
Is HPV testing the practice in your hospital routinely? How do you approach?
Uh, yes, sir. Actually, we don't have a routine practice for testing for our HPV, but those suspicious cases, we do request them to test for the particular parameters.
All right. It was a very nice talk, and very concise. In the time, I think you've really managed well, and it was a recap of all the major lesions to everyone. And I think for the newcomers, they would have got some orientation to the topic. Thank you very much.
Thank you. Thank you.
Thank you, Dr. Vijitha, for such an excellent presentation on pap smear interpretation. I'd like to all the audience kindly fill the feedback forms